the lunch break. So we're now in the final part of our ASM, and we're going to focus now on the research programme for the next 5 years, which Payne and May introduced before the break. So I think first of all, just to I would like just to introduce the programme leadership for the next period, and you'll be seeing some of these people over the next little while. So we have programme leadership in public mental health from Judy Kidger at the University of Birmingham and Louise LaFortune at the University of Cambridge. From Children, Young People and Families, which is Peter Craftnell from Fresh and Dougal Hargreaves from Imperial. Health Inequalities will be led by Claire Bamborough and Jenny Pope from Fuse and Lancaster. And then Fuse and Lilac, but Jenny is at Lancaster. And then Healthy Places, Healthy Planet will be led by Matt Egan from London School Hygiene and Tropical Medicine and Frank de Vogt from University of Bristol. So I'm really grateful to all of these for stepping up to the leadership of our 4 research programmes and helping to develop this in collaboration with our partners, our public partners, and practice partners over this period. Now, what we've done for this is you will be meeting some of these people over the next over this session. But given that the research programmes are a work in progress, what we've done is ask each of them to invite others to give an external perspective and help set the scene of the importance and the priorities for our 4 research programmes going forward. So the first up is our Children, Young People and Families programme, and I'm delighted to welcome Peter and Dougal to the stage, who will chair their session. So thank you both.
Thanks very much, Ashley, and good afternoon, everybody. As Ashley's just mentioned, this session is going to focus on the Children, Young People and Families programme and be an early opportunity to outline some key thoughts, questions and issues that we'd like to grapple with. So shortly we'll have a live talk from Anthony Costello, and then Hannah Fairbrother will introduce a short video based on engagement with young people, followed by some reflections and some time for questions and answers. Firstly, Dougal and I wanted to just briefly introduce ourselves as co-leads. We're rapidly getting to know many of you in SPHR, but these short introductions should hopefully be useful for those of you who have not met us yet. So I'm Peter Craftnell. I'm Professor of Human Geography at the University of Birmingham, and I'm also one of the executive members of the Fresh Consortium. I'm a human geographer by background, but really an interdisciplinary scholar of childhood and youth, and I have broad-ranging interests in children and young people's interactions with their environments. That ranges from their experiences and participation in urban planning, particularly in sustainable urban planning, through to their knowledge and experiences of environmental resources, and most recently a project that looked at children, young people and their interactions with plastics. So I'm really excited about the interdisciplinary opportunities that the school is offering and that we're currently developing through our programme. I'll hand over to Dougal now to say a little bit about himself and to introduce Anthony.
Thanks, Peter, and good afternoon, everyone. So my name's Dougal Hargreaves. I'm a consultant paediatrician at St Mary's Hospital in London, and I'm a reader in paediatrics and population health at Imperial College London. So just as a quick overview, I wanted to mention kind of 3 recurrent themes in a lot of my work. The first is partnership working with children, young people and families. So my doctorate really focused on working with children and young people from 16 sites across the country. And we're really looking at how we could understand the distinct needs of adolescents and work to improve NHS services for adolescents and young adults. And that's a focus I've really continued as my work's probably broadened out to look more holistically beyond just NHS services and at wider influences and determinants of young people's health. A second recurrent theme has been better use of routinely collected data. And again, that started off perhaps more narrowly linking different healthcare data sets, And a big focus in the last few years has been thinking how we can link data on children and young people from health, from education, from social care, and from other sectors, and get a much more joined up, holistic impression of children and young people's lives and how we can support them. And then a third theme has been around policy translation. So I've previously worked as an advisor at Department for Health and Social Care and at Department for Education. And I'm really keen that over the next 5 years, we promote an ongoing dialogue between researchers and policymakers. So not just presenting our findings at the end of a project, but really that ongoing dialogue throughout the project and co-designing work together. So very happy to discuss that if we have time at the end of this session or at future sessions. But for now, I'm delighted to introduce Professor Anthony Costello. So among a very long list of roles and achievements, Anthony is former Director of Maternal, Child and Adolescent Health at the World Health Organization and currently plays leading roles in the Lancet Countdown on Health and Climate Change and the WHO, UNICEF and Lancet Initiative on Children in All Policies 2030. Thank you so much for joining us, Anthony, and over to you.
I hope you can see that and I hope you can hear me. Thanks very much, Dougal. Thanks, Peter, as well. I'm going to make a few comments about challenges and opportunities specifically around adolescent health from both a UK and also a global perspective. And the first comment is, why is adolescent health so neglected? I think part of it is there haven't been coherent frameworks about adolescent or children and young people, if you like. And this one on the right comes from the Partnership for Maternal Newborn Child Health, which I quite like, about well-being and obviously health and nutrition, but also connectedness, positive values, safe, supportive environment, educational aspects, and very importantly, agency and resilience and the links across society. So this is a very important framework, and you'll find others as well. But what always astonishes me is why this is neglected by funders. And there's no real understanding of the window of opportunity, not only to tackle adolescent problems, but also massive adult health problems with potentially huge economic benefits. And I won't read through that list, but you can see it's a massive list where behaviors between 10 and 19 could have a very enormous impact on the prevalence of both disease and antisocial behavior. Another, of course, is that adolescents are hidden from view. I've had 3 in my family. They're now in their 20s and 30s. But this diagram from the Lancet Adolescent Health Commission shows you what I discovered, which is from about 11 onwards, children become much more focused on their peer group and on their phone or social media, and you don't often know what they're up to. And of course, that's both a challenge, but also an opportunity, because both peer groups and media through mobile phones could be a route into children in a way that could be positive. The big problem is, and I sat through meetings at WHO and so many meetings over about 10 years where everyone said, oh, adolescent health is so important. And then when the funding decisions are made, everything is focused on basically condoms and contraceptives. And it's all about stopping STD. This is the World Health Organization page about adolescent health. But again, at the bottom, they're trying to sell preventing pregnancy. And I think adolescents are much more than that. They're like the rest of us in our early years. And there are many more concerns than condoms and contraceptives, important though those are. This is a rapid intuition appraisal that took me about 45 minutes, which I did a few years back when I thought about all the friends of my children. And I worked out that of about 45 I listed in my children's networks, 2 had had manic depressive episodes. 1 boy had been psychotic, 3 self-harmed, about a quarter smoked. All of them virtually were drinking too much, in my estimation. About a third were overweight, obese. 2/3 I didn't think were exercising enough. And 3/4 of them certainly had periods of anxiety and distress over that time. None of them had been pregnant, of course. 3 were gambling semi-professionally, and I didn't know about the other stuff. So this is a big issue. And actually one of my daughter's friends who became a teacher at the age of 25 told me that every day at school, a North London Comprehensive, she would spend 2 hours after school talking to students. She said it was a massive issue because she was the youngest teacher, about all these issues, whether it was stress, self-harming, eating, drinking, being a refugee, divorce, parental pressure. And of course, globally, we know that 1.2 million adolescents die each year. This is not a trivial sum. Road injury being the main cause for boys, and girls still, sadly, maternal issues and self-harm and suicide. And that's why we need to think about them, children, young people, adolescents, in all policies. And this was the main conclusion from the Lancet Commission that was published 2 years ago. You can download A Future for the World's Children. This was jointly with WHO, UNICEF. And I'm not going to go into that, but subsequent to that, first, the key issue from that was that in every sector, I mean, if you go to the transport ministry, road injury is the leading cause of death for young people. Agriculture and trade will affect either malnutrition in the poorer countries or obesogenic diets. Urban planning, 90% of children also breathes unsafe air. And if you look at family services, 40% of children live in informal settlements around the world. And we all know that education is not just about turning up at school, but whether you get some kind of quality education. So these are massive cross-sectoral issues, as Peter mentioned at the beginning of this program. And we have to think about that. Since that commission was published, we've set up something called Children in All Policies 2030. And we think that's important, and 9 countries are involved, and WHO and UNICEF support this. If you want to read more, go to that website, cap-2030.org. Next, I would say we need trials. If you look at the International Clinical Trial Research Program list, that little blue dot in the middle is adolescent health. So very few trials in relation to many other biomedical issues are done. We need trials because they can have impact. I think we need large trials. And if there's very limited amounts of money, because public health rarely gets more than about 4% of all medical research funding in this country, with more than 90% going to biomedicine, which I strongly disagree with, but that's another issue. We need to choose a variety of outcomes. I've listed some there. We can think about both peer group as well as individual interventions, and we need to do economic analysis. So I think if we were going to spend money on this, it'd be better to do 2 or 3 large trials and have a lot of people like you doing smaller sub-projects as you go along. Climate change is massive. Children are very worried about it, as we all should be. But I think we can turn them around from being protesters to participants. And I'll just tell you about one issue that we're involved with at the moment. And we've done pilot work on this, looking at school children and adolescents acting as citizen scientists, collecting information on their mobile phones about their local ecosystems. This is in the Middle Hills of Nepal, where landslides are a very important contributor to not just accidents and death, but to damage to agricultural land. And ultimately, what we want to do is to do a trial of this at scale, where we look at outcomes not only for child nutrition and dietary diversity, but also for land health, looking at green cover, water cover from satellites, and also soil carbon, which is important for future investment. Last couple of points, tap into creativity. You know, teenagers are incredibly imaginative, creative, artistic, enthusiastic, and passionate. They really love to learn and be involved. There's lots of things that you can get them involved with. I shouldn't say this, but they're also very cheap. So that if you've got big projects and stuff, they will happily come and get involved. And it's not going to cost you a fortune, although I do think they should be rewarded. Finally, I mean, as you know, health is political. I'm not saying party political, but it is fundamentally about power and voice. And it's also about what goes on in the international scene. So adolescent empowerment is very important because it embraces changes in agency and her social environment, for example, for speaking out, for also giving them a sense of purpose and meaning when so many are individually stressed. And I'll just, my youngest son was at Bristol University, and during his time there, 11 students committed suicide, which I think is a scandal. And I think there are issues that we could be dealing with through peer groups for that. Finally, this was when we put the child obesity strategy through the World Health Organization. I assumed that it would just be endorsed by everyone. It struck me as very non-controversial. But at the main meeting, there were lots of voices of dissent. So we were sent into another room where we spent 6 hours going over every word of an obesity strategy. And in the end, 2 countries refused to endorse it. A certain USA, which refuses most things, and secondly, Italy. And at the end, as I was then the director, this was about 4.5 years ago, I had to go up to the main. I saw my opportunity because the DG had gone out the room, so I sat there to get my photo. But I had to feed back on this, and I was somewhat less than diplomatic. And at the end, one of the American delegation came up and said, "Dr. Costello, I found your presentation very patronizing." And I wanted to say, well, actually, it's pronounced patronizing and it means speaking down to people. But I didn't, because I was then a diplomat and civil servant. But I'll stop there. I hope that's a few ideas. And I really do hope some of you will get involved in adolescent health, because I think it's an incredibly neglected and important area. Thanks.
Brilliant. Thank you so much, Anthony. That was really challenging. I'm just going to briefly introduce the next presentation. So we have Bethan Miller from the PSHE Association, and she's going to talk us through the development of some PSHE lesson resources all about health inequalities that are based on our research from the last phase of SPHR, exploring young people's perspectives of health inequalities. The resources have just been launched yesterday. And then following Bethan's presentation, we've got a short animation that was co-produced with young people from the research, some of our researchers, and Nifty Fox visual storytelling company. And that lays out some of young people's priorities for reducing health inequalities and sets a real challenge for us as we enter the next phase of SPHR. Thank you.
Hello everyone, I'm Bethan Miller. I'm a subject specialist at the PSHE Association, and I'd like to take a moment today to talk to you about the lesson resources we've developed to accompany the Health Inequalities Toolkit, a fair and equal opportunity to enjoy good health. We've developed these resources for young people aged 11 to 18 with a lesson at each key stage, so key stage 3, 4 and 5, for delivery within PSHE education lessons as part of a universal approach within curriculum time, rather than a targeted one-to-one intervention or pastoral approaches. And at the PSHE Association, our aim is to support teachers to provide high-quality PSHE education to all pupils. And we do this through providing support, training and advice, as well as working in partnership with a range of organisations to develop and quality assure lesson resources. So the opportunity and the need to teach about health inequalities has been brought forward due to the content of the statutory guidance that affects PSHE education. And I've pulled up some relevant topics within this on this slide for you. So while we know that young people need to be able to help to support their own health, for example, through physical activity, food choices, and good quality sleep, we also know that they can have different experiences of the barriers accessing these. So the lessons aim to reduce stigma around health inequalities and support young people engaging with communities and decision makers to help to reduce those barriers to the building blocks for health. We collaborated with researchers and the Association for Young People's Health throughout the development of the resources, from an initial scoping workshop that helped to develop the direction of the lessons, through to taking feedback once there was an initial draft of the lesson activities and teacher guidance to make sure that the key messages were aligned and that they were representative of the findings of the research. And then the final versions, having that final round of feedback, as well as going through our quality assurance process at the PSHE Association, to ensure that the lessons also stuck by best practice within PSHE education. And having this approach with researchers meant that we could develop resources that best represented what the young people in the research felt were the most important messages for other young people to be aware of. We could work this into activities, and we could also put this into teacher guidance to help teachers manage those discussions. Working with the AYPH also meant that we could take the challenges and strategies shared in the toolkit and develop those lesson activities to help young people become more familiar with the characters in the toolkit, and also to explore them in more depth, safely and effectively, as there are differences in lived experiences within our young people in our classroom, which can make it a very sensitive topic to teach about without the kind of guidance that we're able to provide within the resources and the teacher guidance. It also meant we were able to link to the toolkit, and we did this both visually in terms of the kinds of graphics that I used and the colors used within the resources, but also in terms of signposting teachers to relevant parts of the toolkit. As you can see, we've linked to it there with that middle document, which is the teacher guidance. Where it is relevant for students to have a link back to the toolkit, we've included that within the lesson plans. And also we were able to take those characters in the toolkit and work those into activities with case studies and including them in particular activities. So in terms of the content of the lessons, for students who are a bit younger, the lessons focused on rights in relation to health and identifying the building blocks for health, as well as some exploration of actions that can help to address health inequalities. For older students, they start to explore how language, stereotypes, and assumptions about health can contribute towards health-related stigma and how to challenge this, which is then further explored for post-16 students in further depth, for example, on an individual level or on a local area level, which I'll demonstrate in a moment. And as these older students are starting to approach being more independent, we also felt it was really important that they have an idea of strategies to help to mitigate barriers to the building blocks for health and how they can access support. So an example for those younger students at Key Stage 3, ages 11 to 14, you can see on the left-hand side, they're going to be identifying rights in relation to health and the building blocks for health through pictorial representations with the support option for students who need it in terms of those idea cards to match them up. And then on the right-hand side, you can see that they're going to be doing an activity where they're identifying different actions that individuals, communities, and decision makers can take to help to reduce those barriers to health. So in Key Stage 4, there's a bit more depth when young people explore the building blocks for health with scenarios of people who can or cannot access a particular building block for health, and some ideas for strategies about how a young person might manage that with the cooperation of their community or with decision makers. And then on the right-hand side, you can see the exploration of how the media represents health inequalities and how inaccurate or unfair judgments within the media can be challenged. Post-16 students explore how assumptions and stigma in decision-making can affect both individuals and local communities. And while we've drawn upon the research findings throughout the lessons, there's a fairly concrete example here in terms of the local area profiles activity you can see in the middle, where we drew upon findings from young people that safe public spaces like youth centres were particularly important and guided and shaped the key questions around this activity to reflect that. It was fantastic to be able to work with the Association for Young People's Health and with researchers on these resources. So thank you so much. If you have any queries or need to get in touch, we can be found at psheassociation.org.uk.
Health inequalities are avoidable, yet they affect everyone. Therefore, it's important that we understand how different people experience and understand health inequalities. But research only tends to focus on the experience of adults. What about the experience of younger people? Researchers based in South Yorkshire, the North East and London aim to change this by asking young people in their areas about what really matters for their health and what could be changed. So what's the problem according to our young people?
Opportunities to be healthy, when gym memberships, leisure facilities and healthy food are often inaccessible and expensive. I feel excluded from being able to look after my health and blamed for my choices. It's hard to go to the gym and eat well when it's expensive and I feel unsafe where I live. And when I finish late after work, I don't have time to go to the gym and fit in college club as well. It feels like there are structures built in to prevent me from being the healthiest I can be and to contribute to society as a result.
Our young people had suggestions on how to change these inequalities too.
Young people need to be included in research. Our voices and our experiences need to be heard. More investment needs to be made into local areas, and there needs to be safe spaces in the community for us to hang out. We need to be supported to find jobs we are good at and mean something to us so we can contribute to the economy. Structural things like rules and policies made by government need to change so that all young people, no matter where we are from, or no matter our ability, our ethnicity or sexuality, can access the things that help us stay healthy. Most of all, we need to shift the blame away from young people and onto those in power who can make the changes. We are your future. Helping young people to be happier, healthier and motivated benefits everyone.
To find out more about the research and how to include young people's voices in the fight against health inequalities, visit the link below.
Thanks again very much indeed to Anthony and also to Hannah and to the various people who put together that video and that animation, which hopefully have offered a bit of a flavour of some of the kinds of issues that we're going to explore in our programme. We're now very keen to take any questions that you might have, so please post those into the comments. Please also feel free to post comments to both Anthony and Hannah, who will respond in the comments section. So we'll just wait to see if any questions come through. Just while we're doing that, just while you might be typing, I perhaps could just say a little about the three strands that we're imagining for our programme, or rather than imagining that we've been discussing with a whole range of participants through our two workshops and since then, just to give you a very brief flavour of the kinds of areas that we're going to cover, and then if there are any questions we can take those. So briefly, just to give you a sense of the emerging strands which resonate very much with the presentations we've just heard. We're imagining three strands in the programme. The first will be around multidisciplinary approaches to social and environmental determinants and influences on children's and young people's health. And that will indeed include a significant focus around adolescents and teenagers and their views on particularly the kinds of assets that they'd like to see within their communities. A second strand will focus on health promoting and inclusive schools in the form of a range of public health interventions and initiatives, including educational initiatives for children and young people's health. And a third theme will focus on the early years, but the strand will more generally explore a healthy start for life for young children and their families. So it'll have an early years focus, but will be broadened out to explore the lives of families. So those are the three strands that we're currently working up. Just looking to see, I can't see any further questions. I wondered, Dougal, did you want to say a little bit about some of our kind of cross-cutting priorities and perhaps our approach to data as well? So I think that might be helpful for people.
Sure, thanks, Peter. Yes, so in addition to those three main strands that Peter talked about, there's a lot of cross-cutting work going on around participation engagement with children, young people and families, which Hannah's leading. And I think GJ's spoken earlier about the overall approach. We're very keen that alongside the PAN network, so that the main PPIE network, that there's a lot of parallel work really embedded with all of those programs, specific project work, but also very keen to do some methodological about how can we devise and improve really ethical ways, rights-based ways for children, young people and families to be involved in research that affects them. Very mindful that a lot of the ethical frameworks that we work with originally developed from perhaps more clinical or biomedical settings and often developed from adults. And they've often been adapted quite appropriately, but we think there's probably some more methodological work that we can do to really think about how that might be improved or how we can make it more inclusive and more impactful. Then the second cross-cutting theme is around data. I think we realized that each of those strands had a strong data component. And for me, it links very much for those who saw Lucy Chappell's talk yesterday. She was challenging us and encouraging us to think very much across sectors and to think perhaps more holistically and outside the health sector than we have always done in the past. As I mentioned in my but at the beginning, I think we're very keen. There's opportunities now to link data on health, education, social care, and potentially wider data on benefits, on police data and things like that, with appropriate safeguards and transparency in place. Also, lots of links with the physical environment work that Peter's mentioned. So how can we link air pollution data about the quality of physical environment, and really do that in a better way? So lots we could say, but I'll stop there for now in case there's more questions.
I don't think there are, and I think we, in fact, answered Ashley's question as we went along there in terms of how we're involving children and young people. So I think we've reached the end of our session and can hand back to Ashley at this point. Thank you.
Thank you, Peter, and Dougal, and to Anthony, and all the other presenters. And there's a number of questions in there in the comments for Anthony, which have been responded to. So now we're going to move on, and okay. Katie says, "Can I turn my camera on?" Katie, am I on? Yeah. Okay. Good. So I'm now going to come on to introduce our Healthy Places, Healthy Planet programme, and welcome Matt Egan, Professor Matt Egan from London School of Hygiene and Tropical Medicine to this stage, who will lead on this session. So thank you, Matt. Over to you.
Thanks, Ashley. Hi, yeah, I'm Matt Egan. I'm from the London School of Hygiene and Tropical Medicine, and I co-lead the Healthy Places, Healthy Planet programme with Frank de Vogt, who's at Bristol University. And the point of the programme is to look at, to do research into health, place and environmental sustainability. And we're planning it for a research programme that will run for the next 4 years or so, 4.5 years. So what I'd like to do now, as we can't talk about the Healthy Places, Healthy Planet programme in any detail because we're still planning it, what I'd like to do now is to introduce 2 external speakers to talk about the issues more generally and talk about their work. And we're very lucky to get the 2 speakers that we have. So first, I'd like to introduce Professor Hilary Graham, CBE, who's a Professor of Health Sciences at University of York. And then afterwards, I'll be asking for reflections from Professor Sir Stephen Holgate, CBE, who is a champion for the UK Clean Air Programme. I'll give you a quick list of some of their accomplishments. It won't be by any means a complete list, and they can add to anything that's relevant to what they say. But Hilary is part of a Lancet Countdown on Health and Climate Change funded by Wellcome Trust. And Hilary is also Associate Director of the ESRC Centre for Climate and Social Transformation. She undertakes research on public perceptions of health and climate change as part of her role on the NIHR Public Health Policy Research Unit. And Sir Stephen Holgate is founder of the Committee on the Medical Effects of Air Pollution, chair of the Expert Panel on Air Quality Standards and Hazardous Substances Advisory Committee, was a member of the Royal Commission of Environmental Pollution and a special advisor to the Royal College of Physicians on air quality. So that's just a few of the things that both the people you're about to see do. I think I will pass on to Hilary right now and welcome her and leave it to you, Hilary.
Thanks very much indeed for that introduction. So what I thought it would be helpful to do is really to share some thoughts. This is very much kind of thinking in progress. And what I want to do is, in terms of structure of my presentation, is to say a few background points. It'll be very familiar to some of you and maybe less familiar to others. So after the background points, I want to introduce some questions, which I thought might be relevant to the Healthy Places, Healthy Planet theme. And then along with those questions, I'm going to present some data and then finally reach some tentative conclusions. If I can get this to move, which I'm struggling to do. Right, here we are. Great. So some background points. I think we all share an understanding of public health mission, which is about ensuring conditions in which people can be healthy. And climate change, driven by greenhouse gas emissions, is rapidly undermining those conditions. It's a major concern going forward for public health. We have rising emissions despite the COVID drop. And global temperatures are set to breach 1.5 degrees Celsius above pre-industrial levels, which was the threshold that Paris set as the one where we would expect to see, and we already are seeing, dangerous interference with the climate system. And 2 degrees, which was the threshold set in 1992 by the United Nations Framework on Climate Change, within the lifetime of people living today. And some people challenge those estimates and say, well, this is going to happen quicker. Looking in the UK context, the UK climate risk assessment has just been published by the Climate Change Committee just a couple of months ago, and it concluded very high risks from high temperatures and to people and places from river and surface flooding. The National Risk Register, which hasn't been updated very recently, but in 2020, this is from the government, air pollution was identified as the largest environmental risk to public health, and greenhouse gas emissions are the major sources of poor air quality. And just by the way, air pollution is also the largest environmental global risk to health. Importantly, the UK set a legally binding target to reduce greenhouse emissions to net zero by 2050, which is a mere few decades away. But even if we achieve that, and we are joined by global efforts on decarbonisation, global temperatures will go on increasing. There is temperature increases locked into the system now, along with the health hazards that they bring. So just another couple of points about background. I'm sure many in the audience will be familiar with modelling, which points to the major what are called win-wins of mitigation, particularly with respect to health behaviours. So what's promoted is active travel, which is of course emissions free, and I say that as a cyclist. We don't produce any greenhouse gas emissions at all, and boost physical activity, and healthy plant-based diets. Both are lower carbon, and because they've got more fruit and veg and less dairy and meat, health promoting. Now, this is really to get to the guts of what I want to discuss. Framing climate change in terms of its impact on health, referred to as a health framing of climate change, is being promoted as a way of engaging the public, mobilizing public support for climate action. And the Lancet Countdown, on which I am a member, Climate Countdown on Health and Climate, that's its basic premise, that health is a vector, a way of engaging politically and publicly issues around climate change. The WHO also expounds this position. And it's seen as particularly important, this health framing, in high-income countries, which are currently relatively protected from climate change. So the questions I want to ask is, does a health framing have salience for the UK public? We're being invited to consider that it does, but does it? And specifically, do people connect health and climate change? And if they do, in what ways? So I want to sort of set the scene a bit. Now, these look very complicated data, but they're actually, I think, relatively simple in their message. It's work prepared by Simon Munzet, who's works at University in Berlin. And what he's looked at is the wiki in English, which is obviously beyond UK users. It's worldwide English wiki users. And basically he's asking the question, do people connect health and climate change? And what he's done is looked at what are called clicks, where you click on an article and then you click onto another article through that visit. And I've put the sort of explanatory information down the side. The popularity of the articles is expressed by the size of those little balls. Users click between articles on health or on climate change. You can see the pattern of visits is very much within those domains. Much fewer click between them. Very few, less than 0.5% of clicks from climate change articles go to health, and vice versa. And the connections that were made in 2020 were associated with COVID and high-profile events. And Simon has done the analysis for 21, and the big driver of the clicks was actually tracking what the COVID status of Britain was, because it was hosting the climate change conference last year. So questions about the connectivity that people make between health and climate change. I now want to draw on a project that I'm involved with for the Public Health PRU, and the project's on public perceptions of the health risks of climate change. And the project team is down the bottom. And we've done two parts. We have two parts of the project. The largest part is quantitative surveys, and it includes, among other things, perceptions and priorities for action. Plus, we have undertaken qualitative interviews, which includes, among other things, perceptions. So I'm going to start with some data from the quantitative surveys. So we asked them, which of these statements, the respondents, which of these statements best describes your view about the impacts of climate change on people's health in the UK? And as you can see, very few thought it would never have an impact. Around a third said it will have an impact, but it's not having an impact yet. But well over 60% said it's already having an impact on people's health in the UK. So one might conclude that the idea that climate change and health are linked is widely, not universally, supported. But the qualitative findings present a rather different picture. We asked people as an opening question the thoughts of the impacts of climate change on people's health. And there are a selection of representative quotes. I never thought of it in terms of the consequences for human life because other life took precedence. I don't really associate climate change with actual people's health. I don't think a lot of people would relate health per se to climate change and global warming, unless you're living in a specific place where your health may be threatened. I feel like when I think about climate change, I think about the destruction of the natural environment, this natural world. I think about my garden, and I think about the animals in it. So we pushed a little bit. When you think about climate change, what do you think of? Global warming, is kind of talked about as being something over there, not something local. I'm talking very generally, obviously. I think the issues that people can't see it in a way. We're here for short periods of time, yet climate change historically has happened over long periods of time. We can't point a finger to it. We can't, and certainly in England, because I think in England we have a long way to go before climate change. So a slightly different perspective on health and climate change than in the quantitative material, and we're still working through this. And the point I really want to make as a sort of centerpiece of what I want to say is the importance of experience, direct and indirect experience, in making links between climate change and health. I mean, a friend of mine, her house was flooded, and whenever it started to rain, always in the back of her mind was that worry. Some of the elderly people, every time it rained, they'd be ringing me up and saying, what's the river level saying? And we were out there in the community knocking on doors, making sure people are all right, so it can leave a big scar mentally. I'd say definitely air pollution has health impacts. Something on the news where something like, I think it was on the little girl's death certificate, she died of an asthma attack, and a number of the participants talked about that death. Harrowing. So we can turn that back now with those insights and look at the quantitative data. And they too underline the importance of experience. So we asked a question about health climate related exposures without using the term actually climate related. Are you aware of any of the following in your local area in the past 12 months? And we asked, have you personally experienced these exposures? Has a family member or close friend experienced? So we've got three sets of data. And the list we offered was one that included air pollution, flooding, severe heat waves, severe storms, drought, among others. When we looked at climate change concern as an outcome, exposures to floods and air pollution increase the odds of being fairly concerned, as you can see, local and personally, and very concerned about climate change, both local and personal. And it's similar pattern with the perceived impacts on health. Air pollution exposure, or reported air pollution exposure, and floods increase the odds of perceiving climate change as bad for health. We also asked about the priorities for local action, which I thought would be interesting for this particular theme. We asked, what are your top priorities for local government to address to tackle health impacts of climate change? And the two selected, not surprisingly from the earlier comments, were air pollution and floods. The salience of head weights for health, as other studies have shown, is pretty low. And again, the importance of people's experiences. Reporting air pollution in your local area doubled the odds of it being a top priority after controlling for personal exposure, and more or less the same finding for flooding. So just to sort of think about some of the tentative conclusions. The first is the importance of the experience of environmental change. So a lot of our respondents in the qualitative study talked about climate change through environmental change. So they talked about their experiences of environmental changes in the natural world and green spaces in their gardens. So they were talking really about experiences in the places that they lived. The other theme that came up was the importance of experience in relation to climate-related exposures. So climate change impacts on people's health was understood through its exposures, particularly floods and air pollution. Again, the importance of looking at health and climate change in the places that people live. So as a sort of final comment, do people in the UK connect climate change and health? And I would suggest that experience is the medium through which people understand climate change. And science, which is the major set of information that is being distributed through the media, speaks a different language. And I've given you two quotes, which were pretty much widely reported. I won't read the whole thing, but you can see the kind of density and the detached discourse that underpins both those quotes. I think it really raises the question of if we should be reframing climate change around people's everyday experiences rather than their health, but the importance of framing it in terms of people's everyday experiences. And I've put a quote here from an article which I really like. To support public engagement, in climate change, health professionals and policymakers should emphasize climate change as present, local, and personal. And that's my little funding statement. Thank you very much.
Thank you, Hilary. Round of applause from me and a silent online round of applause from everyone else. So I think what we do now is that we'll ask Sir Stephen Holgate to give some reflections. And those watching, while you're listening, it would be great if you also could think of one or two comments or questions of your own to put in. Otherwise, I've got questions, but I'd rather hear other people's than mine. Stephen, are you all right taking over?
Yes, thank you. Thanks very much, Matt. And Hilary, that was super, absolutely brilliant. So thanks for that. I, in fact, gave the medical evidence to the Ella Kissy-Deborah case that led to her second inquest, where air pollution was stated as a major driver, not only to her death from asthma, but the origins and progression of her asthma over 2.5 years of her life. And I think it makes the point, Hilary, that you made, that personal experience speaks far louder in many cases than more and more epidemiology, because we know from population health studies that air pollution damages human health But I think when you start getting the personal experience coming through, as Rosamund Kissy-Deborah so avidly illustrated following the death of her daughter, it really does, shout that in our local communities we do have people like this. And I think what we need as health professionals is to try and look out for some of these case studies, because as you correctly pointed out, translating people's personal experience into a wider context through these case stories is incredibly powerful and something that we've had lacking in this area. The second point I wanted to make is that poor air quality is not just an issue outside in the outdoor air. It's inside and inside buildings, and in particular inside our homes. And as we start to push policies to preserve energy for obvious reasons, the tightening up of our homes and the sealing of our homes leads to potentially an accumulation of air pollutants in the indoor setting, which can become really quite problematic, particularly in overcrowded homes and in those living close to highways and other areas where air pollution can be trapped. And so the point I wanted to make from this, Hilary, is that we should be exploring the co-benefits of cleaning up the air with the short-lived climate pollutants, giving almost 50% of the benefits for climate change, which of course will take years to emerge, but at the same time give enormous health benefits, particularly in cardiovascular and respiratory health. So I haven't witnessed really a real effort to bring these two fields together. And they've developed quite separately in the way that they've emerged. And I think as health professionals, one thing we could do is to draw these two things together. The third point, if I can just finish on this, is that the health professional was the professional that created the tobacco smoke legislation. No question about it. It was the health professionals getting behind the issues on the basis of the evidence. But do I see health professionals engaged and advocates in indoor air pollution? Not at all. Yet they're the very ones treating the diseases that this particular pollution contaminants lead to, so much adverse misery and problems, and then accelerated deaths in our society. So I would like health professionals, in addition to the green agenda, to start beginning to embrace air quality as, and you used the term, I think, or it was used earlier on, the greatest environmental cause of adverse health, and start coming behind this in a coherent, joined up manner to help people understand what the nature of the problem is, to help people connect it with climate change, and to advise patients and carers how they themselves can contribute to improving the climate that we're all currently living in.
Thank you very much. Thank you. I'm going to sort of have a look at the comments that are coming through now, which I think you could both probably see as well. Jenny Poppe has well, apart from congratulating on the presentations, asks if you have looked how, if at all, the survey and qual findings varied across the social groups. Can I read this right? And because their experiences themselves are being varied across social groups, I think it's a health inequalities and different social groups experience question, which John Hume also picks up in his comment. Do you see a difference in the link between climate change and health amongst different groups of people, e.g. proximity of people living closer to industry, major roads, etc., often associated with poverty? So different ways into a health equity question, which could you both, starting with Hilary, have a go with that one?
Yeah, it's an absolutely crucial question. Just to say this, the survey we did in the qualitative study is very much a first stab. It's a top level look. So in the material from the quantitative survey, we control for a whole range of socioeconomic factors, plus ethnicity, plus gender, etc., plus age. And there are differences, but what I've tried to draw out here is the importance of experience. We've got a couple of papers which I can send afterwards, which explore some of those issues. In relation to the qualitative study, we didn't ask about people's social backgrounds. It came out indirectly, but we haven't got systematic information on that. So it's a sort of parked question, but it's really, really important.
So in terms of air quality, there's been a lot of studies across the world on inequalities and the unfair exposure of those least able to cope with pollution. And certainly in this country, there's been some very nice studies undertaken, particularly in urban conurbations. In London, there's been a massive study that's shown a gradient running with social class, which undoubtedly says that those living closer to pollution, such as main roads, industry, fixed sites where air pollutants are being emitted, are those that are suffering most from it. And I think, you know, around the world, you clearly see this. And I think the point I wanted to make on this one, Matt, is that it's not just outdoor air pollution. Yes, of course, living close to roads and in poor parts of our cities is not, it has to be something that's we've got to work against, but it's the quality of housing in these environments, which is also absolutely dreadful. And with moves to push more and more people into unsuitable spaces, such as the reuse of buildings that were offices and factories, without giving thought to the indoor air exposure that these poor people are going to be exposed to, is really unacceptable. And again, I just think it's a matter of visibility of this problem. And I think as public health physicians and health professionals, we've got to give this area greater visibility and start to have serious conversations with our planners, local authorities, and others that influence, you know, these sort of decisions at a high level, not just the medical practice side, but actually where people live and their location and what their problems are.
Thank you. Thanks very much. Question from Ashley. What can we all do to change the framing and discourse?
Well, I think it was implicit in Jenny's question just now, and actually implicit in what I was trying to get across. I think we've got to start with what people are experiencing. I know there's a phrase, the lived experience of this and that. I always find it a bit of an odd phrase because actually all experience is lived. So I'm never quite sure what it means. But I do think we need to talk about what people are talking about. So I think that, that experiential dimension is really important. And just if I could add something else in here, Matt, Stephen very importantly mentioned the Framework Convention on Tobacco Control. And how important it was, and the very many stakeholders, including the health professions that pushed it. If there are people in the room who've had a look at the Framework Convention on Climate Change, it's a completely different kettle of fish. They are chalk and cheese. The Framework Convention on Tobacco Control talks about the supply, it talks about the promotion, and it talks about the consumption. And it's got very clear strictures on what we need to do. It's very evidence-based. The Framework Convention on Climate Change is just a wish list. It's a statement of good intent. And I do think if public health this is a slightly related point, but I do think if public health is going to make a serious intervention, we need to come up with our own convention. We need to come up with what would a Framework Convention on Climate Change look like if it had health and people's experience at its heart. Because at the moment, well, anyway, I've said what I've said, but yeah, so it's a roundabout direct and indirect response.
Yeah. And of course, one of the things that we can all do is to lead from the front, really. So to have our hospitals and primary care settings in some of the worst polluted areas of our cities doesn't really help. having queues of cars and ambulances outside our hospitals, where you've got people on intensive care units being ventilated for COPD and various other chronic diseases, doesn't help. So I think as a group of professionals, we've just got to start taking this seriously. And it's not somebody else's business, it's our business, because we're the ones managing the diseases that all of this is producing. And as we get into the climate change agenda and the anxiety and the stress of flooding and the things that you mentioned, Hilary, you know, it is the health professional who's up at the front line in a lot of that. So we've just got to start adapting ourselves to start talking about these things. And if those case studies you were referring to, the lived experience, which I know you don't like, Hilary, then let's get some more lived experiences out there in the real world so that people can know what we're talking about.
Thank you. Hi, Ashley.
Hello, thank you, Matt. Thank you, Hilary and Stephen, for a fantastic session, and thank you to everybody for all their questions. There are more questions in the chat, and it would be great if Hilary and Stephen would be able to go in there and answer some of those afterwards. But I think what you've done is really lay a challenge to us for our Healthy Places, Healthy Planet programme, and what we might be able to achieve with others in partnership. So thank you very much for your contribution, and thank you, Matt. So now we're going to move on to our programme in health inequalities. And first of all, for this, we're going to play a video. Claire Bamborough, who is going to be leading this programme along with Jenny Pope, is not able to be with us today. She's very sadly having a holiday, but she has prepared some information beforehand. And we've got a video to show you, and then Jenny will be here for a live Q&A at the end of that session. So thank you, and over to the video, please, Katie. Thank you.
Hi, I'm Professor Claire Bamborough, Newcastle University, and part of a FUSE membership of the School of Public Health Research. I co-lead HIP, the Health Inequalities Programme in Phase 3, together with Professor Jenny Pope from Lilac and Dr. Rebecca Mead, also from Lilac. We'll talk about our programme that's in development for Phase 3 of the school. Through our workshops, we've come up with 3 key areas for attention: levelling up and pandemic recovery, improving methods and tools for health inequalities research, and co-produced research with communities. And we're also engaged in dialogue with the other programmes about potential cross-programme projects. In terms of our work that we're proposing around evaluating the government's levelling up policies and pandemic recovery, I want to start by talking a little bit about the context in terms of trends in health inequalities over the last 2 decades. From 2000 to 2010, under the National Health Inequalities Strategy in England, there was a significant decrease in health inequalities between the most deprived local authorities and the rest of England. In this chart, come from School for Public Health Research 2 evidence, we can see, for example, that infant mortality rates the gap significantly declined during this policy period. However, from 2010 to 2020, trends in health inequalities began to reverse. Again, research from School for Public Health Research 2 has demonstrated some of this. Jointly with the Children and Young People's theme, a paper was published evaluating how increases in child poverty have been accompanied by unprecedented increases in infant mortality rates, particularly in the most deprived local authorities. Research joint with the Healthy Places programme has also found that changes in health inequalities have been related, for example, to cuts in local authority spending. So work led by the Places theme by Professor Ben Barr from Lilac found, for example, that with each £100 reduction in local authority funding, there was a decrease in average life expectancy of birth of over a month. These funding reductions were greater in more deprived areas, and so the cuts in funding have been associated with an increase in the gap in life expectancy of over 3%. On top of this, obviously over the last 2 years, we've had the big impact of COVID-19. And in School for Public Health Research 2, We've done a lot of research exploring these inequalities and what they mean for more deprived local authorities, regions and communities. Working with the Northern Health Science Alliance, for example, we've done a lot of work looking at the impact of COVID-19 on the North, finding that deprived local authorities in the North had a much higher mortality rate than equally deprived local authorities in the South. We've also worked with the APPG on left behind neighbourhoods and discovered that mortality rates were even higher in the most left behind, the most significantly deprived neighbourhoods in the country. And working with the Children and Young People's Programme in SPHR2, we've also evaluated the wider impact of the pandemic, for example, on education and learning outcomes, again finding worse outcomes in the North and for more deprived local authorities. We've also set out the idea of a syndemic pandemic, trying to explain why these health inequalities have emerged in COVID-19, thinking through the influence of the social determinants of health and the disproportionate burden of key clinical risk factors amongst most deprived populations and communities. So into this context, the government has launched a big levelling up strategy with the white paper in February, and they've stated that levelling up is a moral, social and economic programme for the whole of government. They have 3 key missions around which include spreading opportunities and improving public services, restoring a sense of community and local pride, and empowering local leaders and communities. They also have a target that by 2030, the gap in healthy life expectancy between the highest and lowest areas will have narrowed, and that healthy life expectancy overall will rise by 5 years. There are various ongoing and forthcoming initiatives that are part of this levelling up strategy, including the Levelling Up Fund, the Community Renewal Fund, the Shared Prosperity Fund, and so on. There's also a Levelling Up Health White Paper, which is expected late summer, early autumn. So in our work stream for SPHR3, we plan to evaluate this multifaceted, holistic levelling up strategy and to see the impact it has on the health and the social determinants of communities across England. We're going to use mixed methods, take a long-term approach, conduct longitudinal, both quantitative and qualitative and economic evaluation, and focus on a multi-scale basis, looking at individual outcomes, neighbourhood, local authorities and regions. We'll also collect data looking at the experiences of diverse communities, coastal, rural, minoritised communities and socially excluded groups. In this way, we'll be drawing across the skills of a diversity of school members, and we'll be able to conduct multiple natural experiments of the various intricate aspects of the levelling up strategy.
Hi, I'm Rebecca Mead from Lancaster University and part of the LILAC membership. I'm here to talk about improving methods and tools for health inequalities research. So as part of our work programme for SPHR3, one of the aims is to explore and improve the effective use of data and research tools to address health inequalities. This will include linking large quantitative data sets to improve our understanding of place, for example, linking health and housing data. Exploring the potential to include new types of data from schools and civil society organisations, for example. Establishing closer links between existing data platforms across the school. And finding ways to improve how the different dimensions of social and health inequalities are recorded and conceptualised by identifying population groups that are absent from these data sources, such as religious groups, migrants, and people who are homeless. We're also seeking to establish qualitative data platforms to host longitudinal narrative accounts of people's lived experience. And we'll be seeking to embed the principle of open access data across all of this work. Clearly, this workstream has lots of potential for linking with other work programmes, and discussions are ongoing with programme leads.
Hello, I'm Jenny Popey. I'm a member of the School of Public Health Research through LILAC, which is a collaboration between the Universities of Liverpool and Lancaster. I'm also co-lead for the Health Inequalities programme with Claire and Rebecca. Claire and Rebecca have outlined two of the three main themes that we're currently developing in the programme. One focused on evaluating the health equity impact of levelling up and post-pandemic recovery policies, and the other developing more effective methods to evaluate actions that aim to reduce health inequalities. The third theme that we're developing is going to be focused on co-creating evidence-based knowledge with groups who have lived experience of the social determinants of health inequalities. In the past, these groups have had relatively little involvement in research and therefore little opportunity for their experience to influence policy and practice. So this theme will also be focused on mobilizing the evidence that is produced from their lived experience. The topics to be researched will be prioritized collaboratively with these groups and where appropriate, with other relevant stakeholders. However, we know that racism as a social determinant of health inequalities will be a prominent theme. Other themes might include, for example, the health equity impact of homelessness, of domestic violence, or of disableism. Over the months ahead, SPHR colleagues will be working with members of the public and diverse communities and with other relevant stakeholders from policy and practice to develop and implement the programme. We will be developing a web page on SPHR's website, but if you're interested in getting involved in the programme or want more information, please go to our Get Involved page and let us have your details. There will be an opportunity for you to ask questions or make comments about the programme shortly. But first, we've asked a member of the public who's been involved in SPHR research in the past, Alan Griffiths, who also has a special interest in health inequalities research, and Professor Kate Pickett, a prominent academic in the field, to give us their perspectives on the importance of a research programme on health inequalities.
Very much for agreeing to talk to me today. Obviously, you and I have known one another some time as a public partner in the School of Public Health Research, and I know you've been involved for a long time in the Applied Research Collaboration, and before that, the Clark for the North West Coast. So I know you have a special interest in the health inequalities field. So perhaps you could just tell us why you've taken such an interest in being involved in that area.
There are two reasons, I think. Chronologically, the first one was back in the 1970s, and I worked for Darlington Borough Council. Now, I don't know if you know Darlington at all, but it has a railway line that runs from London to Scotland, goes right through the middle of the town. And on the right-hand side of the town, the east side of the town, is all the cheap houses, all the 2 up and 2 down, Victorian terraces and so on and so forth. On the left-hand side of the town, the west side, it's all lovely semis and detached with lovely gardens and so on and so forth. And I remember asking my boss at the time, why is that? Why is it split between east and west? And he said, well, it's obvious if you think about it, because back in Victorian times, all the industry was built in the middle along the railway line and the river as well. So the gas works would have been there. Yeah. So everybody who could afford it would live in the west side of town because that's where the wind came from. So they were getting fresh air. You know, they were getting nice clean air from the southwest. The poor people had no choice but to live on the east side of town where they were getting all the mucky air. So that was my first time that I really thought about it. Not so much in terms of health inequalities, but in terms of the right side of the tracks, if you will, you know, and so on. Later on, I was a trustee of Royal Mencap Society, the National Mencap, because I have a son with a severe learning disability and autism and other things. And I was a trustee at the time. They did a campaign called Death by Indifference, which was about 6 people with a learning disability who died in hospital due to the indifference of the staff of those particular hospitals. The person actually, it's a phenomenal campaign. The person who actually ran it got an OBE for doing it, which was well deserved. And that made me really start thinking about learning disability, about health inequalities. And I guess since then, having a son, as I do, I've become, I wouldn't say obsessed, but it's been not far away from obsessed, I guess, but it's a very important part of my life. And I don't know if you know the LEADER project, but it used LEDER, and it used to be Bristol University, but now it's one of the London universities in partnership with UCLan. But the final report from Bristol University, they said that on average, a person with a severe learning disability dies 25 years younger than everybody else. 25.
Shocking.
That's
shocking.
Massive, isn't it?
So from that perspective, we're developing new program around health inequalities.
Yeah.
I just wondered if you would fairly briefly give us just a couple of what you would consider should be the priorities for a program like that. I mean, you know, we've got a broad outline around looking at the levelling up agenda and recovery from COVID, but within that context, what you think the priorities should be?
I think one of them's got to be communities, and it's got to be living in a healthy environment.
Yeah.
And going back to that Darlington and St Helens, where I live now, is exactly the same. The west side of town. I was talking to somebody at the CCG, and he said on average, I think their life expectancy is 8 years longer than the people on the east side of town, which is phenomenal, isn't it? I never, just because you live on the right side of the tracks, yeah. So I think communities is important. I'm not going to pretend that I know how you deal with that, because it's really complicated. But I think it has to be a real priority, and where you live has got to be made healthier somehow. As well as that, and it's difficult because it's going to sound like I'm blaming people, and I'm not. But there tends to be a healthier way of life if you've got a little bit more money and than the people who don't. Now, I don't really understand why that is, but again, it appears to be the case. So if that can be done, Jenny, don't you know, this stuff, I'm interested in all this stuff, but please, I'm not an expert, so don't
absolutely
don't think I am. But there are certain things, aren't there, that sort of stick out like that you think, yes, that needs looking into, and the sort of research. You know, why is it that people with less money tend to eat less healthy food than people with a few quid more in their pockets? Why? I don't know.
Okay.
Do they smoke more? I don't know, but I wouldn't be surprised. Do they drink more? I don't know, but I wouldn't be surprised. Do you know what I mean? Those sort of questions.
Yeah. So before we've finished, we haven't got very much time, and you haven't. You mentioned when we were talking earlier about, you know, that you didn't think a focus on just social determinants was enough. I just wondered if you could very, very briefly elaborate on that a little.
It's kind of the difference between health equality and health equity. You can, I think you can get health equality just by looking at social determinants. But in order to, I mean, we always talk about in the learning disability world about the reasonable adjustments. And all you've got to do is make reasonable adjustments for people like my son, and then you can achieve health equity. That's the way I look at it. You know, I think. But having said that, you've got to try and achieve health equality before you get anywhere near health equity. I believe.
So what you're
tackle
talking about,
the big issues first.
Yeah. So what you're talking about is the need to look at different dimensions of inequality, aren't you? Whether it's disability or other dimensions like racism and that kind of idea, really.
Yeah. As I say, in my case, it's more the people with disabilities who, you know, it's not a social determined. Nobody determined that my son has a learning disability. It's just an unfortunate thing that happened when he was born, and unfortunately, you know, I mentioned the death by indifference thing, I mean, unfortunately, there's still evidence that even today there are people in the NHS and probably people around who think that the quality of life of somebody with a severe learning disability isn't worth spending the money on. And that's really, really sad.
Yeah. Okay. Alan, that's been brilliant. Thank you very much for sharing your wisdom with us. It's always great conversations with you. And I look forward to working with you on the School for Public Health's research in the future.
Me too, with you.
Hello. I'm really glad to have a chance to talk to you as you get together to celebrate 10 years of achievements in the School of Public Health Research and look forward to a further 5 years of work. It feels like a really important time to be thinking about the future of public health, not just as we come out of the COVID pandemic. We've, of course, learned a lot of lessons and need to be thinking hard about how we take those forward in our research and in our activism and campaigning in public health. But also, I think it's helped us to focus on what we knew about the pandemics that we were already experiencing before COVID-19. You know, we do have a pandemic of morbidity and mortality related to climate change, and to pollution, air and water pollution, among others. We've got an obesity pandemic as well, and of course a rising pandemic of mental health problems, especially anxiety and depression, which are reaching such critical levels among our young people. So all of those existing and new pandemics are challenges to us as we think about the future of public health, the research that we need to be doing and the actions that we need to be taken. Of course, we've also now got a war in Europe, perhaps unimaginable to many of us a year ago today. And the repercussions of that war for public health are quite hard to see at this time. We don't know how the war is going to unfold, but there will be short-term, medium-term, long-term repercussions of that war, both direct actions in the war, but also, of course, the consequences of what that war means for our society, our communities, our economies at this time. And the cost of living crisis that is facing us now feels really frightening to me. It feels like we're on the brink of seeing a lot of suffering, a lot of devastation, with potential for short-term impacts on health and well-being and long-term impacts as well. We know that the stress of experiencing financial insecurity is as bad as the material suffering that is caused by it. We know that that source of long-term chronic stress is going to be affecting people's health even after we come out of a cost of living crisis. The stress that is built up during that period will continue to resonate throughout people's lives. Now, we have a levelling up agenda to grapple with. We have a government that talks about being committed to a levelling up agenda. We need to think hard about what that means for us and whether or not we are seeing the actions taken that really truly will result in a reduction in socioeconomic inequalities and a reduction in health inequalities. It's not enough to have an agenda. It's not enough to have the talk. So it's up to us as public health professionals to hold the government to account and make sure that they do take action to level up and create a more equal society with higher levels of well-being for all of us. And I'm concerned at this time that we're hearing language about health disparities instead of inequalities. We're to expect a new white paper on health disparities. And I really want us all to commit to not falling into that error of our American colleagues and not labeling inequalities as disparities. We mustn't do that. We must stick to our language of social justice. We know that differences in health between groups in the population are an injustice. We know they're inequalities. They're not just differences. And we need to make sure that we talk truth to power when we express our belief in those concepts. Levelling up needs to be about addressing poverty. It needs to be about addressing inequality. It needs to be about ensuring good work for people. And we all know what we mean by that and what bad work looks like. But it's also, of course, about democracy. It's about agency. It's about power and voice. It's about what we need to be healthy in a holistic sense. Levelling up needs to be about making sure that everybody in this country can have purpose and agency, but importantly, be connected to one another. So we need to think about community as we go forward and the social connections with participants in our research, the communities we work in. We need to be committed to connectivity and co-design and co-production in meaningful ways. So as we continue to seek to promote the health of the public and to create a healthy population in a healthy society, in a healthy economy, we do need to make sure we do keep on speaking truth to power and that we hold our values very dear and display them very openly in all the work that we do. So I wish you all the best for the next 5 years, and I hope you can really make a difference. Thank you.
Oh, hi. So I'm Jenny Popey. You saw me earlier. It's quite an odd thing to see yourself speaking to yourself. So Claire, the co-lead of the program, and Rebecca, who's in the leadership team, have left me holding the stage here. Although I see Rebecca is commenting in the chat. This is an opportunity for you to ask any questions. I may not be able to answer them straight away, but we'll come back with answers. So, but just I'd like to say two things. One is that was a very important call for action by Kate there around the social inequalities that drive health inequalities, and the programme will be prioritising producing evidence about how we might address some of those structural inequalities, primarily locally, but also regionally. And also just to say that the programme is not the only place where there will be research on health inequalities. The school is committed to have an equity lens across all of our research, and an intersectional equity lens that moves beyond the traditional focus of public health research on socioeconomic inequalities. So I've got I'm monitoring the chat as well here. And I saw that Laura Kudma did make a point about data, which Rebecca has answered. But just to say, Laura, that we have a methods work strand that will be looking at what data are available already to do place-based work within as well as across local authorities, which was the question you asked, and what new data we might need. So we're aware of the constraints there, and we'll be doing our best to contribute to that, to improving that. And then there's a question from John. Hi, John Hume, People's Health Trust. Hello, John. He says there appears to be a positive UK data on the impact of discrimination, how it is embedded, affects biological processes, harmful to mental and physical health. Will you be focusing on this pathway between discrimination, oppression, and direct impacts on mental and physical health? So, John, again, the methods work strand. This is an early stage. We're developing the detail at the moment. So, but in the methods work strand, we absolutely will be looking at discrimination in general and particular forms, so racism, disableism, etc., and what kind of data we need, what kinds of questions we might need to ask in quantitative data, what kind of proxy measures there might be in the short term before new data can be collected. And we also intend to do some work across the work strands. So particularly, for example, work strand, the second work strand, which is the one co-creating research with some of the groups that, some of the marginalized, racialized groups that have been most neglected in public health research in terms of their direct involvement. We want to do some work with them about how they are represented, how their experiences are represented in data, and also, of course, how that data is used. So it will absolutely be a focus of the work that we're doing. Another point that John Hume raised earlier, I saw as a kind of comment, was the startling analysis by the Health Foundation that the 5-year improvement in healthy life expectancy that is in the Levelling Up white paper as an aspiration could take 192 years to achieve if the trends from 2017 to 2019, I think it was, continue. That is salutary, it is shocking, but of course, it's not inevitable that the 2017-2019 trend should continue. COVID may well have lengthened that time frame now, but Claire's slide also showed that between 2000 and 2010, the improvements were much quicker. So, and of course, historically, we know, for example, when East and West Germany came together, there were dramatic improvements in life expectancy in the east of the new Germany. So what we know is that with the right policies, that 5-year improvement can be speeded up for sure. I wouldn't even hesitate to guess at how quickly it could be done, but it could be done in a lot shorter time period than 192 years. And hopefully the research program will make a contribution to identifying policies that can speed that improvement up. So I think we've run out of time anyway, so I'll hand over to Ashley.
Thank you so much, Jenny, and also to everybody else speaking in that session. Really fascinating, and I saw that air quality again came up, and of course we're going to have Chris Whitty, the CMO, speaking at the end of today, and I know that air quality and pollution is very much on his agenda too. So I'm going to move us swiftly on to the final of our 4 programs, and to introduce our public mental health program, which will be led by Louise Lafortune from Cambridge and Judy Kidger from Bristol. And we have Louise with us this afternoon. So Louise, over to you. Thank you.
Hi, good afternoon, everyone. I'm Louise Lafortune. I'm based at Cambridge Public Health as principal investigator for SPHR. And over the next 5 years, I'll have the pleasure of joining Judy Kidger from the University of Bristol, who's not on stage but is in the audience today, to co-lead the next phase of the school's public mental health program, building on the amazing work of the current leads, coordinators, peer researchers, practice stakeholders, PhD students, and academic. For this session, we invited 3 speakers to tell us why they think focusing on public mental health over the next 5 years is still a priority for the school. I think some of you, for those who were there, you will have seen in yesterday's presentation that we've traveled a long way in SPHR2, but the presentations have also shed light on how much further we need to go to address and also redirect the current trends in mental health, both at the population level and at the individual level. We know we have to look at children and young people at key transitions across the life course, also develop better ways to engage and work closely with people in disadvantaged, vulnerable, or stigmatized group to develop relevant evidence. And also it will be important not only to develop evidence that is people, context, and setting specific, but to build on what we've learned from one settings and subgroups and transfer that knowledge to the other subgroups so we can really gain traction on a number of issues that we need to address. So I'll just quickly share just a few slides before we move on to the speakers. I'll try and share my screen, and if it doesn't work, I will not use the slides. Perfect. So you should all see my slides now. So for those of you who were able to join the sessions yesterday afternoon, you will have heard David Osborne's summary of the outputs from the public mental health program in SPHR2. But for those of you who were not able to attend and join us, you can find a summary of the program on the website, as well as a lot of examples of outputs and statements from the peer researchers who have worked with us from the MEPIN Foundation, as well as with practitioners to really roll out the program. You can find more details about the work that was conducted for and with children and young people, adults and older adults. You can also revisit or discover for the first time the conceptual model for public mental health, which really highlights a lot of the determinants that we are hoping to focus on, not we're hoping, but planning to focus on in the next phase of the school. And you can also find out a bit more detail in how the public mental health network works and how you can join, because we are going to carry on with that wonderful engagement and hopefully bringing more people on board. So over the last many months, the school has held a number of series and workshops with public practice and academic collaborators in relation to all the programs. And what you see on the slide here is what went into the business plan and the main ideas that were identified in relation to public mental health. So we will draw on the conceptual framework and the evidence from SPHR2. We have that the win in the right direction to build on the outputs and also the new outputs that are coming out. We'll take a life course perspective. The focus will be on evaluating new interventions or natural experiments with a clear focus on addressing inequalities and equity, and also embed a group of health economists to help us understand the value and the cost related to the interventions and the added value for the system. We'll focus with that information on changing the system, carry on with co-producing the work with a range of stakeholders and external partners, including members of the public, both people from MECPIN and as well other groups who might not have had an opportunity to engage with the school program before. You'll see, or you may have noticed already from the conversations this morning and yesterday, that there is a clear overlap and a clear need to find synergies with the work that is being developed with children and young people, as well as in the health inequality program. And there is a strategy coming out in December from DH that we will make sure we take on board. But just for those who are not aware of it, there is an open consultation at the moment. So there's a discussion paper available. The open consultation is open. So if you do have a lot of things to say, I'll put the link in the chat in a few minutes. Now, I will stop sharing my screen. There we go. Just to say that we have held 3 additional workshops with members of the public practitioners and academics over the last 2 months or so. And we are at the stage of bringing together many of the ideas that we've heard before. We had a panel last week with a conversation around 20-something projects that came in, project ideas, and are developing the framework that will be submitted and discussed at the executive in July. So we're making great progress, and I'm really looking forward to talking to you a bit more about that. But without further ado, I'd like just to introduce our speakers, and then I'll see you at the end for the panel discussion and the conversation. So the first presentation is going to be a pre-recorded presentation from Davino Beckford. Davino is a peer researcher and an evaluator at the MECPIN Foundation. But although he has a recorded presentation, he's going to be with us for, at the end for the panel conversation. It will be followed by Professor Martin Knapp, who is Professor of Health and Social Care at the London School of Economics and Political Science, as well as Director of the NIHR School for Social Care Research. And the last speaker will be Joanne Smithson from the What Works Centre for Wellbeing, where she had the implementation and learning, as well as the local government and health sector lead. So if I could have Davino's presentation, I hope you will enjoy our speakers. Thank you.
Hi, my name is Davino Beckford, and I work as a peer researcher at the MECPIN Foundation. I'm currently working on a project with Black Thrive, which is a project essentially aiming to improve the employment outcomes for Black people living with long-term health conditions in Lambeth. I also work as a children and young people's public involvement and research coordinator, facilitating multiple young people's advisory groups. I am and have been interested in public mental health as someone who has lived experience of mental health struggles, as well as knowing some of the struggles of navigating the mental health system. As a result, I want to be able to contribute, however small, to improving the mental health and well-being of others. Over the past 2 years, I've been using my personal lived experience expertise alongside my skills as a psychology graduate to deliver a range of projects at the McPin Foundation. It's been an interesting time because I started this work during the pandemic. That has been challenging on lots of fronts, but one good thing to emerge is increased public awareness of mental health struggles. This puts an even greater emphasis on public mental health too. So I'm pleased to be talking to you today as one member of the public, but thinking about many, many other people up and down the country. Mental health is of course an important focus for the School of Public Health Research. I know it has been a program over the last few years, and I'm pleased mental health will be a dedicated program of work in the next phase too. It must be, because despite all the work being done to improve the outcomes for people affected by poor mental well-being, we are only scratching the surface of what there is to be done. There are so many unanswered questions. Like, how is racial trauma experienced by different marginalized groups across the UK, and what bespoke supports and solutions do we need in place to tackle racial trauma? How can we reform systems such as education, criminal justice, health and social care, and welfare so they are less likely to cause and exacerbate individual trauma experiences? So I'm really pleased mental health continues to be a focus in the School of Public Health Research. And it's hard to untangle mental health from some of the big issues facing our society. Poverty and the cost of living crisis, conflicts, including refugees fleeing war zones, climate change, the aging population experiencing loneliness, widening inequalities. In my opinion, I think one of the biggest issues faced by the public regarding their mental health are inequalities and the oppressions they cause. We need research to help us find solutions and increase understanding, and the public are a huge resource to help us do that. So of all the areas I could talk about, why inequalities? Because the focus of my work largely for the past 2 years has consisted of work in racial equity, addressing the current employment system that seems to be failing for Black people, those living with disabilities, and those at the intersection of this. I was part of a working group, all of us representatives of our local community. We were given resources to fund local projects to make a difference for Black people. We took a long time, meeting regularly to decide how best to set up this funding program, how to make decisions, and then who to fund. The community funding model is very powerful, and I saw how small grants can lead to new ideas and partnerships being born. People ran with these grants, empowered by the investment and the belief in them. We also adapted the process so people who found it hard to fill in forms could submit a video application. If you want to be inclusive, you have to change your processes. I think that's important for research too. Additionally, as a children and young people's PPI coordinator, I have helped facilitate multiple YPAGs that are focused on involving young people in research. One in particular was a YPAG supporting a project tackling anti-LGBT bullying in schools by investigating how whole school interventions can be used to improve the mental health of young queer students. This project was rapid. It was a 3-month piece of work funded as part of the Wellcome Trust Active Ingredients program, but it brought to the fore lots of issues we need to follow up on. By taking an inequalities approach to improving public mental health, the focus shifts to things that the current mental health system cannot solve. We not only seek to improve the mental well-being of those receiving the care, but also dismantling the systemic barriers, attitudes, and behaviors that we know also contribute to poorer mental well-being. I like the focus that public health takes to looking to the community for solutions, not only in NHS settings. I know that research funded by NIHR, including the School of Public Mental Health Research, places a strong emphasis on PPI. It is interesting to think about what that means for public mental health research. Who are the public? Aren't we all the public? I understand that currently the approach is to consider different public perspectives for individuals who have experienced forms of trauma. This is a good approach and opens up avenues for a lot of people to contribute up and down the country. We want to involve diverse public expertise in the next phase of the public mental health program. One idea is to have multiple different dimensions and layers of involvement to give people choice. This would include the public in employed roles such as peer researchers, integrating them in project teams, and having a PPI coordinator anchor role embedded in the research program. We want to make it a greater priority to welcome more community organizations, link the projects into this research program. It would also mean having public partners involved as advisors on individual projects. A key priority will be both reaching new and diverse audiences with involvement opportunities and building strong relationships with all partners, including between academics and the public. The more we integrate our expertise, the better it is in my experience as someone with feet in both the lived experience and the researcher's shoes. Thank you for asking me to contribute to this meeting today. For this program to continue to be a success in my eyes, we need research that is useful and that is not just research for research's sake. We need research that will actually address inequalities and therefore alleviating the impact they have on people's mental well-being. I know I might be one voice speaking here today, but I am basing my words and intentionality behind them on all the work I have done and have been doing thus far in my life, as well as sharing my perspectives and experiences of those I encounter as a young person living in London.
Hello. Gosh, that was really powerful, wasn't it? Thank you so much, Davina, for sharing those thoughts with us today. I'm Joanne Smithson. I'm from the What Works Centre for Wellbeing, and I'm going to talk to you today about our approach to wellbeing. We're going to explore what our priorities will be for public mental health research and explore maybe how, if we add a wellbeing lens to our research, or we maybe add a wellbeing metric to our research outcomes, the difference that could help in terms of building the evidence base of what works to improve public mental health. Just before the pandemic, there were an estimated 4 million people with low wellbeing in the UK. 4 million people living in misery. From my perspective, it's really important that our 5-year research programme to improve public mental health is wellbeing creating, it's salutogenic, as well as supporting those with the lowest wellbeing. So I work for a What Works Centre. We're part of the UK's national network of What Works Centres. Some of the centres you may have heard of are the Early Intervention Foundation, the Centre for Ageing Better, or maybe the National Institute for Health and Care Excellence. We're all What Works Centres. And together as part of the What Works network, our aim is to improve the way in which governments and other organisations create, share and use high quality evidence in decision making. It's about supporting more effective and efficient public services at local and national level. And as Janelle Tarushi discussed earlier before lunch, it's about supporting decision makers as well, helping people make choices with a deeper understanding of how those policies or interventions will affect people's lives. It's great today that we're celebrating 10 years of working together for public health. It's about 10 years ago when colleagues, including Professor Kevin Fenton and the former public PhD, nurtured the concept of a What Works Centre with a focus on wellbeing. They incubated us within PhD and then set us out to be fully established in our own rights. But that programme of measuring national wellbeing has been around for 10 years. You know, in the UK, we're really the envy of many nations in having this amount of data that we have. Many of our core big quantitative data sets have wellbeing measures included. So we have not only a longitudinal series, but we have a set of metrics, the ONS4 metrics, that can help us understand how we're doing and the impact of our services on people's lives. But when I talk about wellbeing, what do I mean? Broadly, it's about feeling good and functioning well. The Office of National Statistics, the ONS definition, is wellbeing is how we're doing as individuals, as a community, and as a nation, and how sustainable that is for the future. There's a real strong capitals and futurity element to that as well. Broadly, it's subjective. It's how we feel in ourselves and how we experience life as a whole. So if we were to have a public mental health research programme that maximised wellbeing and reduced wellbeing inequity, what would it look like? One of the first pieces of work we did at the centre was some public dialogues about what does wellbeing mean to you? And 3 areas came out of that. The first one was feeling safe. So feeling safe financially, so understanding financial insecurity on what builds financial resilience. Feeling safe in terms of good physical and mental health, a primary driver of our individual well-being. About access to food and good food, about feeling safe in our jobs and employments, in housing, in access to natural environments and transport. The second element that came out was feeling loved, feeling respected and appreciated, feeling that we belong, having positive connections, and also time alone, having an appreciation of difference, and a feeling that we're part of something bigger. The third one was about feeling fulfilled, that sense of achievement, of inspiration, of feeling valued, having fun and joy, learning, opportunities, having control, agency, and choice. So across all of our programs that we've been hearing about today, I would love you to think about how in your own programs you can build outcomes and understanding of feeling safe, feeling loved, and feeling fulfilled. Wellbeing offers us a really practical opportunity to inform public spending. It allows us to compare across interventions, and we see that life satisfaction measure in many frameworks, in the National Outcomes Framework, in the Public Health Outcomes Framework, and in the Levelling Up White Paper as well. I know Claire didn't mention it, but the government has set wellbeing as an overarching goal of the Levelling Up White Paper. Life satisfaction can be used as an outcome across a range of different spends. In our recent review, we looked at what works to improve personal well-being and found things work across housing improvements and thermal efficiency, skills training, volunteering, physical activity, social prescribing, psychological interventions. Lots of different things work, which is why a wellbeing lens can help. So in terms of 5 takeaways, our priorities: making wellbeing an outcome of your research, focusing on the outcomes that matter, feeling safe, loved, and fulfilled, looking at communities and connections. Really keen to hear today the experiences of the ideas and shaping of children and people's programs, because 50% of our later adult wellbeing is determined by a life under 18. So building on the work of GM of Greater Manchester, for example, looking at children's wellbeing is super important. Suicide prevention. I'm thinking particularly here of the groups that haven't had contact with health services or mental health diagnosis. It's absolutely no coincidence that those curves we see for antidepressant and suicide rates and life satisfaction are the mirror images. That purpose and meaning piece is really important. I hope we bring forward programs on workplace and workforce wellbeing, because we know that again is a primary driver of wellbeing. And finally, because I'm an evidence centre, I want us to be great at evidence synthesis and getting that information out there so we can all share that. So I'm really grateful to be part of the conversations today, and would urge you to support and join with the What Works centres to share that knowledge. Thank you.
Thank you very much, Joanne. So it's Martin Knapp here. I'm going to share my slides. Oops, going to share my screen. Okay, you can try. Okay, I am now failing to share my screen.
Hi Martin, if you just go to the big share button and then click share screen, and you should be able to pick out your PowerPoint in the application window.
Yep, I'm not at the moment. Okay, sorry. All right, apologies for that. 0 out of 10 for competence. So I just want to quickly pick up on some of the things that have been said by the previous speakers, and just to emphasize a couple of links that I will hope the new program in the school is going to be picking up as it goes forward. So wide horizons is what I want to pick up on. Firstly, I mean, this is a very familiar picture to many people. This is the global burden of disease, the big international study, which looks at the impacts of different conditions and what impact they have on our lives at different ages. What you can see here is the global burden, the disability burden as it's called, of mental health problems, mental disorders by age, by gender, and the width of the bars is the extent of the impact. And what we can see in these early years from early teenage through into early adulthood, this very rapid growth in mental health problems. This is where many mental health problems start, and their consequences are likely to be seen, we know will be seen, if not properly addressed, throughout the life course. So that is why, one of the reasons why we really do need, and I'm delighted to see that the new school has this big program in the mental health area, reminding us this is the Faculty of Public Health definition of public mental health, which is breadth and depth of action. So it's thinking about what needs to be done across different parts of society, public and private, within communities, by individuals, and so on. So that then takes us to something like this. I've got two groups of things here. These are examples of some of the risk factors for poor mental health and some of the protective factors for better mental health and mental well-being. These are things that these are just some of many other conditions, any other experiences that could be included, genetic risk, stressful life events, a whole range of things on there. And what we need to understand is how those actions earlier in life or at one point in life can head off some of the problems, some of the difficulties that people will have later on. So I hope that the program will be able to address, I'm sure the program is going to be able to address a number of those areas. Joanne just mentioned some of the issues around income and economic position. And if you haven't come across it, I would just recommend this very excellent paper in Science from a couple of years ago, which is a wonderful review of the links between poverty, particularly depression and anxiety, but some hints about other mental health problems, and trying to unpick some of the causal mechanisms. It really is a very excellent review and lots of useful references. So I just want to put that in just to emphasize the importance of that dimension. Now, the other sort of economic theme I want to bring in, because I do a lot of work myself in the area of economics and mental health, is the economic case that can be made for public mental health interventions. There's some little pictures of things we've done at the bottom there. Let me just pick out three examples. One would be investing in social and emotional learning programs in schools. What you can see from the little graphic there, yes, there are costs of putting those programs in place. They take up time in the curriculum. They require inputs and commitment from parents, from teachers, from others in schools. But the economic payoffs over and above the well-being and health payoffs, the economic payoffs are considerable and certainly outweigh those costs of the intervention. A second example would be in the workplace, where we know that well-being programs, again, there are costs. I put bosses in there because I couldn't fit employers into the font size, but there are costs to the employment setting, to bosses, to companies, to organizations, but the payoffs to a whole range of bodies, including them, those companies and organizations, the payoffs are much greater. And then thirdly, another example, a different area of a community intervention. This is debt advice by, for example, Citizens Advice Bureau, where again, there's a cost involved in delivering these services, these advice services in this case, but the payoff in terms of heading off mental health problems, helping people who have them already to adjust to them, to take control of their lives, if you like, the payoffs can be enormous in economic terms too. So the other thing I just wanted to put into this very short presentation is something about the other areas of the NIHR, in particular the social care area, which I head in the School for Social Care Research. We now have across the three NIHR schools, public health, social care and primary care, some very exciting programs. We have two additionally funded programs. One is in mental health, which is led from the primary care school, and one is in dementia, which is led from the social care school. And what we're seeing across those different programs is some really exciting, new and exciting collaboration between researchers and then policy and practice groups in those three areas: public health, social care and primary care. And with that, I will say thank you and just look forward to seeing the exciting things in the school in the years to come. Thank you very much.
Hello again. Oh, Joanne and Davino. Okay, thank you very much for these really interesting conversations, and it's reassuring to hear some of your ideas in light of what is already developing in the program. And I know some of you have been very involved in sharing ideas already. And as we progress the program, we'll certainly take a lot of what's been told, what's been discussed today. I'm conscious of time, and there are a few questions, but one question was to Davina. It's been answered by GJ, who was asking how we can make, how we can move to a more collaborative, community-involved funding model across all of our work. And I see, Davina, you already replied to GJ in there. So I'll let you read this a little bit, and I'll just make sure we address the other question. That was a question from Laura to you, Joanne, about how we can address the challenge of local authorities and using the different types of data you mentioned, and if you think the ONS could do, what the ONS can do to give local authorities better personal well-being information to inform the decision from rolling up.
Thank you. So we've got those in the OHID fingertips. We've got, if you search for self-reported wellbeing, you can find those 4 metrics from a local authority level. We've got them broken down as well, so we can see them for people with low wellbeing and people with high wellbeing. So you can look at the differential wellbeing in an area. The challenge we have is the sample size isn't great enough. But for some local authorities, we can't get that really important differentiation to allow us to understand where are those groups of people with the lowest wellbeing. So we'd really love to see a bigger sample size or a greater collection of that data to allow local authorities to focus their efforts on wellbeing in place on the areas of lowest wellbeing.
Yeah, thank you. In the program, we do have a methodological stream, and one that is quite interested in looking at data for better health locally. And this is an interest across other programs. So I think across the school we'll be able to progress that question. And also just to mention something that Martin touched on about the 3 school programs around mental health. If you go on the SPHR website, there is a section on the mental health program where the description of the projects that are co-funded across the school, whether primary care, social care, and public health, are listed. And with that, you can get in touch with the team or us if you need to know more. So in the interest of time, I think I have to stop here and give a chance to the last speaker of the session. But I just want to thank you all for your input. Very much appreciated. We will feedback through the program and keep asking questions, and I'll make good notes of them. Thank you all.
Thank you all very much. And right on time, it's my absolute pleasure to welcome Professor Sir Chris Whitty, the Chief Medical Officer for England and Head of the Public Health Profession, but also someone who needs no introduction, having been the calm voice of evidence and reality throughout the pandemic. Chris has always been a great supporter of SPHR and joined us last year in the annual scientific meeting. Chris, I'm delighted to welcome you back to offer your reflection on our forward research programme, but also some perspectives on your perspectives on public health improvement. Just to say, Chris, I believe you were willing to take some questions, so I'm going to encourage my colleagues and the audience to put some questions in the chat while you're speaking. Hello.
Hi all. Can you just check you can hear me, Ashley? Yeah, great. I didn't really want to have a kind of long spiel. I thought I'd just make a few general points and then really leave it open to people to ask questions, to which I'll give extended answers, because then I'll do it on things that people are interested in. I think the first thing is that coming out of the pandemic has had some huge wins for research in public health, and also some quite serious challenges for us. The wins have really been, I think, a very clear demonstration to policymakers and to the public that if you base things on solid evidence and solid research, you get a much better outcome than if you do it more randomly. And that's not in the area that most of you are working, but that was an extremely important demonstration, actually. And having a situation where Prime Minister, senior ministers, leaders of local councils, as well as, of course, people running bits of the NHS and social care were exposed on a daily basis to public health data, I think did open their eyes to really quite the extraordinary power that's there. However, it also highlighted some really serious issues. The first and the most important really was that it highlighted some major areas of inequality and disparity around the UK that all of us knew were there, but I think had really been underappreciated. It's surprisingly, you might say, but underappreciated in quite large areas of the work. But and there's a but to that. It also, I think, took the spotlight off some other areas that are equally important. So, for example, I think it made clear the dearth of data we have on public health information in social care, for example. And I think it demonstrated, again, the centrality of obesity and overweight in what we do as adults and risk factors. I think a lot of people were really taken aback by the fact that obesity increases risks of infections as well as of cardiovascular diseases and mechanical diseases, for example. But on the other hand, I think it took the spotlight away from many areas of public health in children. And children suffered very badly during the pandemic, largely due to the lack of schooling, and are likely to be affected very significantly by the economic ramifications of the really quite seriously worrying cost of living crisis that is already on us and is only set to get worse over the next year, with inflation and a group of other associated problems at really quite extraordinary rates by recent history standards. So I think that it's shifted attention to some areas and away from others, and alongside that, it has made many areas of research that all of you are involved in a lot harder. So the fact that the NIHR swung an enormous amount of its energy and resource over towards COVID was exactly the right thing to do for the crisis, but as a result of that, it has led to quite significant difficulties for areas of research that are equally important in the long term, but were not the crisis of the moment. And standing some of the research back, and I'm sure this affects all of you, has proved a lot harder than we thought it would. It's quite in a sense we found closing things down easier and standing things up again harder than I think we probably would have predicted overall. Turning to some of the points of substance, I think all of the areas that are being looked at in the four main themes looking forward are absolutely central. And I don't think anyone would dispute any one of them. I'm just going to major on a few themes, not because I think they're more important, but because I think they're illustrative. The first of which is, I'm going to go back to the point I made about obesity. I've been working with colleagues on how we can improve issues around obesity, around smoking, around alcohol as part of the white paper in health disparities that are coming on later. These are well-known risk factors. We've been thinking about them for a while. And yet, if we look at even these areas, which I think are well recognized as major issues in public health, we all have to accept that the research base for what we need to do about these is quite patchy. And I think what all of you are doing is providing systematic evidence of what works in different areas where the risks are, but also how we can do something about them. I would be very interested in your views on where you think we can help you to essentially research more effectively solutions to the problems that we face. The problems I think are easily described. The solutions I think are often rather harder, and they certainly get harder when we start having to interact with industry in a variety of ways. For example, have to interact at the joining points between local authorities and central government, local authorities and the NHS, social care, and other effector bodies across the UK. So I think your sort of clear steers to us as to where we can provide you help, I think, would be very useful. And then the second point I wanted to make was about health inequalities. These are already, as we all know, bad. They are set to get worse. We all know that as a result of what is happening at the moment. One of my slight worries is that we're quite good at identifying the sort of the classical health inequality problems, but we have proved less effective, I think, at coming up with solutions for them in some of the more difficult areas. I did my annual report last year on coastal towns, just as an example of a problem set that's repeated all around the country. We could equally have done looked at problem sets around how we tackle inequalities in ethnic differences in health, inequalities in rural health, which is a very serious issue, and so on. So I do worry that the description of the problem is really well done in the UK. The solutions, I think, we are not as strong on, and that becomes really clear when we start having to try and write policy and work out what to do. And we know exactly the problems we're trying to address. We are on much weaker ground when we are coming up against organised resistance to what we're trying to do, because they will say, well, where's the evidence this is going to work? And the honest answer in a lot of areas is, well, it's there, but it's not massively strong. And that really brings me to my final point, and then very happy to go in any direction you want on any of the themes, or indeed any other area you're going on, which is my constant concern that we think very hard about how difficult a solution is going to be to bring into effect, either because it's practically difficult, because it's expensive, or because it's politically difficult. I mean, small p, politically difficult, will have a lot of pushback. And that the more difficult something is to do, the stronger the evidence base has got to be. Because if something's easy to do, then you only need a kind of very weak evidence base. You can say, look, this is probably going to work. And people say, fine, it's free, it's popular, go ahead. The more challenging it's going to be, the more the evidence base will be challenged. Sometimes very formally, as the cigarette industry absolutely invariably does through the courts, more often through kind of just soft pushback on multiple dimensions. And we've seen this recently with obesity. We're going to see it with quite a lot of other areas, I think, as we go through the health disparities white paper. And it is only when we have strong evidence that things work that we can, with some confidence, win the argument. Because even if we then have to wait a bit to bring things into being, if we get serious pushback and we don't have an evidence base that what we're arguing for is likely to do what we say it's going to do, we tend to lose fairly fast, actually. So, I mean, we rely in the policy sphere absolutely on what all of you are doing to produce the evidence to allow us to push forward public health. Anything we can do to help you provide that evidence base is something I would really want to hear from you. Whether it's you think resources could be put in particular new areas, whether you think there are certain barriers to you getting access, for example, in local authorities, whatever the barriers are, I really am keen to unblock them, because we won't make progress in public health until we actually have an evidence base, and you're the people who obviously help to provide it. I think that's really generically what I like to say, Ashley, but I really would, very happy to go with any specific questions in any particular area. And you're on mute.
Thank you, Chris. And there's lots of questions coming in. I think just to pick up on one of the things you've just finished with there in terms of working with local authorities and perhaps potential barriers. This has been a discussion over the last couple of days, but also pre that, thinking about the health determinants research collaborations which will be coming online, and how we unlock some of the rich data sets and link some of the really rich data sets that are held across local government, to be able to use those in informing our health and our health research, and then creating the evidence to make a difference. So perhaps you could comment a little bit on how we might be able to unblock some of those barriers.
Yeah, so I mean, I think if you think, I mean, it is a constant problem, not just with local authorities, but more widely, as to the UK has some of the richest data from some of the most unified systems in the world, actually. I mean, it's really interesting working with places like Germany, extremely good scientists, but they've got their federal systems make it very difficult to link data together. So we should be in an incredibly strong position, but that isn't realised very frequently. The reasons for it not being realised are multiple, obviously. But most of them are relatively soluble. And I think actually COVID demonstrated that. So we managed to combine data from local authorities and central government and the academic sector and the NHS unbelievably fast when we were faced with a crisis. So there isn't actually a technical barrier. We brought in people with outside expertise to do it, including, I have to say, from places like GCHQ, but they weren't doing anything that was any different from what is possible within the law now. They just essentially all barriers were removed and it happened. So we know we can do it. There isn't really a technical reason why it can't be achieved. There are some difficulties. There are some problems around money. It will cost some money, but I think the gains everyone recognizes. So the thing where it always, in my experience, founders is two things. The natural but unhelpful tendency of everyone to wish to guard quotes their unquotes data, and I would doubt anybody on this call couldn't really claim that they haven't at some point in their lives thought, oh, that's my data and I haven't yet analysed it properly, and why are you trying to nick it and get all the publications and everything it is? And everybody else has their own reasons for wanting to hold their own data. And then the second bit is, and this I think is one that is my problem to try and help solve, and I tend to have a go at it. In fact, I was discussing this with colleagues in the Southwest earlier this week, is lots of people are really nervous that they'll get in trouble if they release data. This is particularly from local authorities. It's not they're hanging on it for academic reasons, because they're worried about data protection.
Yeah.
And there's a real fear of the law, which is stoked up by newspapers and so on as well. But people are scared of the law, and they're scared of running afoul of data protection, and the terrible things can happen if they get it wrong. So I am intending there's a new data commissioner, and I'm intending to try and make a relationship with them and see if we can actually say jointly, look, guys, actually the presumption is in favor of you doing this, rather than you're going to get in trouble if all the risks are on release of data. So I think the final thing is the law itself undoubtedly is unhelpful, but getting legislative time is going to be tricky. For reasons of history, health data was exempted from laws that actually allowed us to merge data from multiple other sources. And that was done in good faith by people at a particular time, under extreme lobbying from groups like Med Data Confidential and a variety of other groups, which are usually 3.5 people and a dog, essentially, but they're incredibly good at getting their case across, and they're very paranoid about this. But the fact is the law is where it is. And we may have to find some workarounds. For example, I think we may have to find third-party safe havens, ONS as an example, where data can be lodged so that data isn't transferred from local authorities to us as researchers, but it's put into a third-party environment where we can then work on it and merge it to other areas. But so I gave a long answer because I think I agree this is a really major issue.
And one that we keep coming up against, and I think is we have got a program within the school where we're looking to see how we might be able to facilitate this working with others. So if there's anything within the school that we can contribute to those conversations, we'd be really happy to do that. And I know a number of our colleagues have got lots of skills in data linkages and so forth. So it would be great to be part of those discussions.
Well, I think the thing which I would find most useful on that is examples where, if the data were merged, a good public health outcome would occur, of one that would be recognised as a public good rather than an academic good. I think that really, the more examples I can give, the easier it is to make the case in government.
Right. We had a great example from some of the work that's been done around child health and contributing to the Child in the North report and so forth. So yesterday, so we can share that. Okay, so I have a question here about post-COVID recovery, so we've positioned some of the context around pandemic and post-COVID recovery, if indeed we ever get there, in terms of running through our research programs. Is there any particular aspect, specifically related to COVID-related policies or post-pandemic impacts, that you think the school should focus on more than others?
Well, I mean, I think I wouldn't want to say what the school should focus on, but I'll say what I'm focused on, and then people can choose what they think is appropriate to what the school wishes to offer. We've always known that what had to happen during COVID, particularly lockdowns and then subsequent social NPI interventions short of lockdown, we knew that these would have a very major knock-on. And I broadly divide them into four for the sake of argument that I think the school can help with. The first of which is we thought there would be, and there definitely is already, a big knock-on in terms of cardiovascular mortality and morbidity. And we're seeing a lot of an excess of middle-aged deaths, particularly in men, mainly at home, which is highly likely to be cardiovascular. The attributable fraction of that, is that due to people not coming forward and getting statins? Is it people not getting health seeking? We don't know, but there's no doubt it's there. So there's a whole bunch of things around that we don't understand and we need to try and recover from. Second, I think we've always known that, and I think this is not yet started properly to feed through, but it will, that this would have a knock-on in terms of cancer, late diagnosis in particular. And what can we do to, again, accelerate away from that? But the breakdown of screening services, people not going to GPs, a variety of other areas. Anecdotally, we know that there are late presentations already happening, but that hasn't been systematized. But I know that was predicted from the beginning, and I think it is likely to feed its way through. I think we need to think through that as well. Third area, I think that there has been a really major hit to children, and particularly around mental health. We know that there's increases in obesity. We know there's an increase. There's a really shocking, actually, increase in eating disorders. But there are probably quite significant other ones as well, in addition to physical deconditioning and a variety of other areas. So I think child health is an area where we've got a lot of recovery. The danger is we could end up with a generational scarring if we're not careful on this one. Yeah. And then the fourth one is the socioeconomic effects of the economic long-term damage that's been done. Actually, COVID is part of that, but in fact, the war in Ukraine is going to have a really quite major impact. I mean, it's driving a lot of the impact on fuel inflation, which is going to hit us very badly next winter, and it's driving some of the inflation in food, which is also going to have an impact. So I think it's a multi-system problem. The next winter is going to be terrible, I think, in some areas of the country, and I think we need again to think that through. So I think those are four that I'm worried about. There's plenty more, but I mean that's certainly from my point of view priorities.
Yeah, thank you, Chris. And I think in looking at some of those, the inequalities fits across that, because reduction in the cancer screening, children's obesity, and it also link into the socioeconomic effect. And we had a great presentation on the impact of poverty on children yesterday, and that widening inequalities, including obesity. So with that in mind, you might have predicted this kind of question. The evidence for impulse buying, buy one get one free, is in healthy foods is clear. You've mentioned obesity, but of course that's been backed down in terms of within the obesity strategy. Any suggestions on how we push these kinds of policies on obesity prevention and through?
Yeah, so I think buy one get one free was. I'll just deal with that specifically, because it was possible for people to make the case that this was a cost of living issue. Now, it wasn't, but what I'm just saying is that one was, you could almost make a case as to why now was not a terribly good time. The one that I thought they couldn't possibly make the case was actually advertising, where there was no logic to that at all, and it just went through. And some of this fundamentally is about the rough arts of getting stuff through political systems, and lots of people with feet on the brake and relatively few people with feet on the accelerator, and getting ambushed at the last minute when there's not much you can do about it, and so on. So that, in that sense, there's not much you can collectively do on that. That's kind of something we can do in government. But I would go back to my very first point. The stronger the evidence base we can put, the more possible it is to fend off self-interested or indeed well-meaning but wrong interventions from others. And the assembling the data that demonstrated that they buy one get one free actually cost people more rather than less was absolutely critical, even to getting in the first place. And arguably the data wasn't quite strong enough actually to be able to fend it off at the last moment when we had some issues. Yeah, the stronger the data, the more able we are to actually do the kind of the dirty end of politics, if you want to put it that way.
Absolutely, and I think the evidence on advertising, and again that was presented yesterday on the Transport for London, in the impact of that, and on advertising, there seemed to be no logic about that being and saving people, costing people money. If there was no logic there, but it was lumped together. I guess one of the things that you mentioned there about evidence, but also that acceptability of that, and thinking about how and what's acceptable to the public and what they like. And I guess that's about how we bring the public voice to that argument, and whether you've got any comment on that, on how we engage the public in this debate.
Well, I think that when the first stage is get the evidence right, but the second stage, which is how do you present the evidence, is really also very important. And that's less of a research skill, it's more of a how do you actually, there's engagement of the public at the beginning. What are the important questions? That is absolutely essential, and that's substantively important, and that's obviously been a key part of NIHR. But in this area, where people who don't like the answers will pray the public mood in their favour, and the 2 points you made on that we discussed on obesity are an example of that. Actually being able to frame the argument in a way that works in the public sphere is really critical. So we've not just got to convince ourselves. If we can't convince ourselves, we're absolutely lost. But even if we can convince ourselves, we've got to make an argument in a way the public accept, and in language which they find resonates. And I think we're not always brilliant at that, if I'm honest. There is a certain amount of wishing to preach to one another and demonstrate our own wonderfulness to one another, rather than actually say what is the language people are speaking and what's the things that will turn them off in what we're saying, and how can we not sound as if we're middle class preachy people, but actually as if we're on their side.
Thank you. And we had an interesting discussion this afternoon around climate change, and about framing that in public health terms and what's meaningful for people's experience, rather than some of the very technical language and things in which things are framed. So I think this can speak across many different areas of public health. There's a question here which is sort of related, and then I'll move us to a different topic, which was about what tips are there in terms of how research findings can be translated into evidence and into practice. And you mentioned about ensuring people were involved in designing the research questions right from the beginning, and we've very much been doing that across our programs. So it's about that translation into practice.
Well, I think there actually it really does depend on who the target audience is, but if the target, very crudely dividing public health into primary prevention, secondary prevention, I think it's quite important here. If you're talking about secondary prevention, actually a lot of the target audience is health professionals. Yeah. And you've got to frame it in a way which they would recognise as strong evidence, in the way that they understand strong evidence. Now, that's fine if you're someone who's just done a randomised trial. It gets a lot harder if your evidence is actually very good, but comes from qualitative social science, which people are less good at assessing. So I think that's the first issue, is who's the audience. If you're dealing with primary prevention, you're generally dealing with policymakers who are non-health background and the general public. And that obviously leads to very different ways in which you have to frame the way you've got the answers. In both cases, you've got to have asked the right question. And 8 times out of 10, when someone says to me, why is my research not being taken seriously? The answer is, in policy terms, the answer is because you haven't asked a question that is policy relevant. You've done it very well, but it's not, it wasn't a question designed to be turned into policy. So I think the biggest thing is to actually get the question right in the first place, and then to answer it extremely rigorously. The third thing is then to communicate it in a way that people find works for their starting point rather than your starting point. But those are all obvious points, I think.
Yeah, so I'm going to, I think this is a related point really, but this is a question from Ronna Campbell, who's our academic capacity development lead, and she says, from your vantage point, when it comes to research capacity development, where should we be focusing in the next 5 years? And that's specifically around the sort of public health improvement capacity.
Well, I think what we need to do is look very clearly at the areas where we are underperforming relative to need, because those are, there are some areas of public health research, and indeed every other form of research, where the research is moving incredibly fast, it's highly influential on policy, things are changing, and we don't need to build capacity there, it's going to build itself. There tends to be a virtuous circle. There are other areas. Let me take an example of social care interactions, public health in social care, or public health in nursing homes. There is really very little done in those areas, and what we need to do is work out why that is and who we need to bring in to help us. And they may not be our normal, the people we normally work with. It may be that they are from completely different areas, engineering or anthropology or education or wherever. So I think that the key is to actually go to the areas where we are weak and build up those areas, which is often a slow and painful process, bringing in people from other areas, rather than worrying about building up in places where we're strong, because they will always look after themselves. And I wouldn't want to be the person who runs through the list of where we're weak relative to need, but we all know where they are, I think, in our own areas.
And I think this is something that we're hoping to do in some of our transdisciplinary fellowships that we're going to offer to look, perhaps people whose work is important to public health but don't necessarily see them as working in public health, and how can we engage in that. And I think particularly some of the work around air quality and climate change might be an area for those bringing in further disciplines. Chris, thank you very much. I'm aware of time, and I know that you'll be needing to go. I'm very sorry. There are a number of questions coming up here that I haven't been able to cover, but I'm just going to repeat to the audience the question that you gave us, which was for us to think about what can be done within NIHR, within Department of Health and Social Care, and across to actually help us to do the research that we need to do. And data is one of them, but there are others. So I'm going to ask my colleagues to come back through us on that, so that I might be able to bring that back to you. So just to remind everybody of that, and again, offer our thanks to you, Chris. Thank you very much for coming in this afternoon, being so generous with your time, and also answering so many questions.
Yeah, well, thank all of you, because so much of what we do depends on what you have done in the past and will do in the future. I mean, it really, I cannot emphasize too strongly that it's lack of evidence that's the biggest barrier to many of the areas that I'm trying to get things to happen with my colleagues. Okay,
thank you very much, Chris. Okay, everybody, that's thank you all for that. I just now leaves me to draw this meeting to a close. I very much hope that you have enjoyed this celebration, and finishing with that opportunity to discuss with the CMO. Over the past 2 days, we've had over 200 people registered and be part of various parts of the meeting. So thank you all for joining. I wanted to start by thanking our platform host, Beacon House, and Katie Whitehouse, who's worked behind the scenes and ensuring all of us who were meant to be on camera have been on camera and appeared calm, and our videos have worked. That's thanks to everything that's been going on backstage. We've had some excellent presentations from researchers, from our fellows, from our public partners, invited speakers across the 2 days, and across our plenary and our expo. All of those are going to be available after the meeting on our SPHR website, and I'm going to just ask one of my colleagues to post that in the chat, so that you've got that, but it'll also be on the SPHR YouTube channel. We will send you an email after this meeting, everybody who was registered, with that link, so that you'll be able to access that. And please do share it with others and colleagues that weren't able to attend. That all has run so smoothly, and that we've been able to have such a packed programme does represent a massive amount of preparation and planning, both by our speakers who've done all of the pre-records that you have seen, but also the massive preparation from our directorate. I just want to close by offering really sincere thanks to our school manager, Dr. Susan Bowett, training manager Andy Soule, our knowledge exchange broker Katie Appleby, and admin support from Laura Fennick, and also from our new comms manager, just started a few weeks ago and has done a lot to contribute to the programme, Amy Johnson. I really hope that this meeting is giving you some inspiration and also lots of things to talk with each other about and to think about what we can achieve going forward. I know I very much look forward to us all working together and across all of the people who've joined today, the academics, our fellows and practice and policy colleagues. I hope that we can work together over the next 5 years to really improve public health across England and beyond. And with that, just thanks to you all for your contribution. Have a lovely weekend, and we'll see you again next year, but many times in between. Okay, thank you.